All right, thank you so much. Like Catherine said, my name is Rebecca, and I'm an oncology clinical nurse educator at Insight, and have the pleasure of introducing Dr. Hepgur this morning. So Dr. Mehmet Hepgur is a physician specializing in hematology and oncology at Broward Health Medical Center. He is board certified in hematology, medical oncology, and internal medicine. Dr. Hepgur earned his medical degree from the Istanbul School of Medicine in Turkey. He completed his residency in internal medicine at the University of Buffalo, State University of New York, and a fellowship in hematology oncology at the USC Keck School of Medicine in Los Angeles, California. Dr. Hepgur received the 2013 ASCO Conquer Cancer Foundation Merit Award for his work in changes of circulating tumor cells and markers of inflammation after cilta-cel T treatment for prostate cancer. In 2014, Dr. Hepgur received Best Research Presentation Award presented by USC Norris Comprehensive Cancer Center for his research on prostate cancer biomarkers. He is affiliated with the American Society of Clinical Oncology, the American Society of Hematology, the American College of Physicians, and the Southwest Oncology Group. His special interests are genitourinary cancers, immunotherapy, gastrointestinal tumors, benign and malignant hematology, clinical trials, and research. Welcome, Dr. Hepgur.
Thanks so much for the presentation, and I'm honored to be here. Today, we're going to talk about COVID-19 pandemic and impact on cancer patients. As you know, and everybody knows, we've been dealing with COVID-19 since last March, and this actually changed our behaviors, the way we approach the patients, the way we approach the cancer patients, and how we treat the patients. So we're going to talk about these different aspects today. Okay. All right. Okay. So our objectives, essentially, we're going to look into see how COVID-19 disrupted cancer screenings, because this is an important aspect of cancer care. We would like to identify cancer patients before they become symptomatic. That's had some significant impacts. Obviously, this impacted cancer mortality, so we are expecting more patients would die from COVID-19 related issues. And also, our cancer management have changed, including cancer care, chemotherapy, palliative care, and end-of-life issues. So we're going to discuss all these issues, and then I will have some questions for the topic, or if anything needs to be clarified. So COVID-19 is a global epidemic, and I recently accessed to CDC website, and as of last week, there was almost 30 million cases in the US, and there were 531,766 total deaths, and those numbers are rising daily basis. COVID-19 is a coronavirus called SARS-CoV-2. Essentially, this is another variant of a coronavirus we have already known in the past, but this is a different variant, and it behaves more differently and aggressively in patients. Obviously, the patient's symptoms really varies. Older adults with severe conditions like high blood pressure, diabetes, or heart disease, and obviously cancer, they're at risk for developing more serious complications, and outcomes can be devastating with respiratory failure, organ damage, stroke, and death, as we know. So obviously, cancer patients are at risk, one of the vulnerable patient groups against COVID-19. I will briefly talk about how the COVID-19 basically spreads around and causes damage. So when the virus is inhaled, as any other upper respiratory tract infection virus, the COVID-19 basically binds to the epithelial cells in the nasal cavity and start replication. There's a receptor called ACE2, which is a very common receptor in the body, and that's the main receptor. And then as the virus replicates, it migrates down the respiratory tract and moves itself to the airways and finally to the lungs in some patients. And immune system actually utilizes a robust reaction against COVID-19, and sometimes that immune reaction may damage the organs, including lung, heart, and then causes all the pathogenesis associated with COVID-19 infection. And if the patient is essentially having a severe infection, and also the response is very severe, that ends up with significant lung damage, and then the patient going into respiratory failure and eventually die. Again, majority of the patients do have mild disease, and disease is limited to upper respiratory tract. Those patients do have common upper respiratory tract symptoms, maybe some taste loss or loss of taste, sense of smell, which eventually improve. But 20% of patients actually progress into advanced disease and develop lung and other symptoms, which can lead to hospitalizations, ICU visits, again, being connected to the respirators and such. Again, fatality rate varies markedly with age. Younger and healthy individuals develop less severe illness. However, the older individual, frail ones, actually develop more severe illness. So as far as the timeline is concerned, incubation period is about 5 days. During that time frame, the patients are not aware of their symptoms, and actually they can spread their symptoms, spread their viruses to the other people. And then after 5 days, the patients do develop fever, cough, fatigue, muscle ache, joint aches, diarrhea, lack of appetite. And during that time frame, 40% of patients develop symptoms with breathing, and almost 14% of patients do develop severe illness, and then 5% develop critical illness with respiratory failure and such. And obviously, different treatments has been formulated, different approaches. Obviously, this is not our topic today. We're not going to talk about this. We're going to move into the how the COVID-19 affected cancer care, and how the patients are affected. Because I want you to understand that this is not just a medical issue. There's also psychological, ethical, and ethnic backgrounds to the problem. So let's start with a case presentation, a typical patient. This is a 50-year-old patient, presents to the emergency department recently with back pain. She has no significant past medical history. She has a primary care physician. She routinely gets a mammogram, and the last mammogram was due in May 2020. She lost her job and she lost her insurance, and she basically was scared that she would get COVID because that was the height of the disease, of the pandemic. So she basically delayed her screening. And then eventually she noticed a mass in the breast around June, which has rapidly grown. She thought it was a pimple. She thought it would go away because she was scared to go to the hospital. And then eventually, once her symptoms becomes unbearable, she decided to go to the emergency department. And once we worked up on the patient, it turned out the patient had bone metastasis, advanced disease, and it was stage 4 breast cancer, which could be easily diagnosed back at the time the initial symptoms started, and could be treated with curably. Now the patient has stage 4 cancer. Unfortunately, there is no chance for cure. So what are the immediate impacts of COVID-19 to patients on healthcare? So in the US, COVID-19 is responsible for increasing case, hospitalization, and deaths. Obviously, this condition led to stress in the healthcare system. It caused shortages with protective equipment, hospital beds, workforce, because we have to divert many of the nurses and doctors to deal with these patients. So we have to pull them out from their duties and basically divert them and relocate them in the COVID-19. So it caused tremendous effect on the healthcare in general. Obviously, CDC and other governmental organizations immediately enacted multiple policies in an effort to limit the spread. In general life, quarantines has been formed, lockdowns has been done, some limitations to certain services. In medicine, obviously, cancellations of non-essential Medicare care and has been implemented to reduce the spread. And also there was PPE shortage, so we just wanted to limit the PPE use. Obviously, these delays cause delays in routine cancer screening. Obviously, if you limit the cancer screening for a while, you will see the implications for that, because we already know that screening for certain cancers like colon and breast, for example, it leads to early diagnosis and actually improves the patient's outcomes. And if you don't do that, obviously, it's going to make things worse. So for this reason, National Cancer Institute predicts that this will lead to 10,000 excess deaths from breast and colorectal cancers alone in the next 10 years. I will be talking about that in a minute. So in March 2020, CMS, Center for Medicare, and CDC issued guidelines. Basically, the purpose was to reduce the risk of disease transmission, reduce risk of harm due to deferred care, and efficient use of PPE. And during those recommendations, obviously, routine screenings were in the lowest category. Obviously, if it's been determined that we should defer the care if it's unlikely to cause a patient harm. For example, if a patient has a breast cancer, for example, if the patient has a stable situation, delaying the, for example, mammogram in a month or so wouldn't do any harm. Then in this case, we can delay treatment. But let's say if you have a patient with BRCA mutation positive, high risk for cancer, needs a mammogram or breast MRI, for example, then in this case, we would go ahead and do it. So that's the reason it didn't apply to all patients. Again, telehealth was implemented with potentially postponement of in-person visits. We also implemented in our offices as well. And again, in-person care was also recommended. Let's say if the patient is at risk for delayed care, or if the patient is old, cannot access to the telehealth service, or the patient is living in a rural area. So in-person care obviously has been performed for these patients. So importance of early diagnosis, right? As I said, cancer is a complex set of diseases, prognosis influenced by timing of diagnosis intervention. For majority of the patients with different type of cancers, if you diagnose them early, it's better for the patients because you can capture those patients without developing stage 4, in other words, metastatic disease. So we can treat them with surgery and we can make them cancer-free, and their outcomes and survival is actually much, much better. That's the reason we meticulously screen patients over and over again based on our data, and we continue with that. And we prefer not to delay those kind of things because, again, it may negatively impact the outcomes. Again, the earlier treatment, the better the results. So how did the COVID-19 affected cancer screening? Again, like I mentioned, federal guidelines along with the state and local regulations, and in an effort to prevent the spread and limit the use of protective equipment, they slowed down the in-person routine cancer screening during the spring of 2020. And I'm going to talk about these numbers in a minute, but if you look at the new diagnosis of breast cancer, colorectal, lung cancers, pancreatic cancers, or esophageal cancers combined significantly fell during this period. Obviously, if the patient don't come to the hospital for screening, those patients cannot be diagnosed early. So not the patient being diagnosed doesn't mean that the cancer rates are coming down. They're probably left undiagnosed. Again, significant declines were observed in screening amenable types such as breast, colorectal, and lung cancers. Imaging also went down. If you look at the data from the Appeal Healthcare Research Network, the cancer screenings especially for breast cancer went down, especially in March and April. There is some rebound after that, but still the weekly volumes remained low than pre-COVID-19 levels, especially for breast, colon, and cervical cancer screenings. Just keep in mind, we have like different types of patients require screenings. For example, we have breast cancer patients who has been treated for breast cancer. They got screening. We also have patients with no prior history of cancers, and they also require screenings. So essentially, the patients who get screened, if they have a breast cancer history, were actually more thoroughly screened. Actually, most of these patients got their screen, but again, the data showed that the patient with no prior history of cancers who were like being screened less meticulously in their primary care offices, there was a significant decline. Again, although there was a rebound, still the levels are lower compared to last year. Similarly, for the lung cancer screening, low dose volumes essentially has declined significantly, up to 72% during the COVID-19 period. Again, after May, there is some rebound has been seen, but obviously I don't have any recent data, but this must be getting even better now. We have the vaccination as such, so we do have some improvements. Again, report on mammogram utilization showed that mammography volumes started rebounding in 2020, and by the end of July 2020, diagnosed mammograms reached levels similar to those levels in previous years. But again, screening mammograms remain somewhat below expected. These are the mammograms for the patients who has not had any breast cancer before. These are screening mammograms. So those patients probably are left behind and they were basically like lagging. But when you look at the patient who had breast cancer, those patients probably kept in the system because actually they are like more high risk. This is not just a breast cancer issue. All cancers across the board disappeared from the hospital. When you look at the ER data, which was published, when you look at the patients with the ST elevation, myocardial infarctions, they went 38%. Heart attacks, strokes, even appendicitis, they disappear from the hospitals and the ER. This happened partly due to that. The patients was fearing that coming to the hospital for their symptoms would basically cause COVID-19 spread. They were intimidated and they chose not to come to the hospital. But obviously this means that the patients probably had their symptoms and essentially passed their symptoms and passed their conditions untreated in the hospitals, and it will likely require follow-up visits in the future with serious illnesses, for example, infections for appendicitis or abscesses, or maybe a cardiomyopathy for a heart patient who hasn't received the appropriate care because of this. So again, this is not just a oncology problem. This happened all across the board. Again, the cancer diagnosis fell significantly during the pandemic. Again, this is partly due to the fact that the patient did receive less screen diagnosis. And again, probably the patients did not come to the hospital as often. So there was a recent study published in Journal of American Medicine journal. Basically, they looked at cross-section study of 278,000 patients, and they looked at the baseline compared to last year, and then COVID-19 period in March and April. And majority of patients were women, median age 66.1 years. And when they looked at the baseline, they identified that the number of newly identified patients were 335 versus 2,205. And again, during the pandemic, weekly numbers fell 46.4% all across the board, with including these all common 6 cancers. Again, if you look at the all cancer types, significant drops has been reported in pancreatic cancer and 51% drop reported in breast cancers. Again, the mean age of the cancer patient in COVID-19 period was within the 1 year of that the patient was in the baseline period, so they're similar age group. Again, only esophageal cancer were slightly older, but this is unprecedented. This is essentially very significant in terms of diagnosis. So when you look at the graph, you can see that here, this is the baseline period for breast cancer. And then this is the weekly March 1st, and then March 8th, March 15th, March 22nd, March 29th, April 5, and April 12th. So obviously this is only weekly period, but if you look at that, so at the very last week of April, at the time of the study, compared to the baseline weekly numbers, there was a tremendous, almost like close to like 50% drop. And similar trends can be seen, especially in colorectal patients and maybe lung cancer patients towards the end of April. There was a significant weekly downtrend volume. Again, there is overall trend down in basically pancreatic cancers and esophageal and gastric cancer, but just keep in mind, those cancers cannot be screened. So although there's a decline, so many of the patients usually comes in with symptoms and such. But if you look at those first 3, those are the cancers can be screened and can be identified early. So which means that we're going to have a significant problems within the next 10 years for these unidentified patients. Probably those patients will show up as stage 4 disease. And then when you look at the numbers in total, again, there is, significant downtrend in terms of diagnosis. So this is essentially a negative picture, but again, after May, there was a rebound. So I'm hoping that we're going to catch up and we're going to do some damage control for the long-term outcomes. Again, this is not just limited to the United States. Lockdowns and limitations to healthcare occurred in all countries globally. Similar findings reported in other countries. Netherlands Cancer Registry essentially reported 40% decline in weekly cancer incidence. United Kingdom has experienced 75% decline in referrals for cancer. Again, these countries basically have socialized medicine. There may be more government involvement in terms of lockdowns and such, so their actually declines are even far greater than the United States. So how can we make up with these missed cancer figures? Can we catch up? That's the biggest question. Again, data shows that there is a rebound in summer 2020, but despite the rebound, there's still a large backlog of delayed patient visits for cancer screening. Again, if you look at the EPIC data, there was estimated missing visits of 285,000 breast patients, 95,000 colon cancer, and 40,000 cervical cancers. They missed between March 15 and June 16, 2020. Obviously, it doesn't necessarily mean that all these patients has cancers, but again, some of the cancers actually has been detected with these screenings, and which means that we're going to be missing significant amount of patients during that time frame. Again, there is estimated like 36,000 missed or delayed breast cancer diagnoses between March and June 2020. So in order to catch up, the healthcare systems have to operate at or above the pre-pandemic levels. But obviously, this is a big challenge because some of the healthcare systems are high capacity. So if they go over their capacity, they may compensate for that. But again, with the healthcare systems with low capacity, if they don't have the enough workforce, you don't have the equipment to catch up for these visits, a backlog will still continue to grow, and that can be a significant public healthcare issue. Again, like I mentioned, lack of workforce, capacity, obviously patient fear and safety concerns is an issue, because although you tell the patients that it's safe, the hospitals implement different types of measures to prevent spread. The patient may be scared of viral transmission. The patients may not come back. Obviously, there are risks of renewed lockdowns because there are still some unknowns. There are new strains has been reported, and the data on the new strains are limited with the vaccination. So we don't know whether these vaccines are very safe or not against these new strains. If the new strain may cause another spike, these are the unknowns. Again, racial, ethnic, socioeconomic, and geographic disparities has grown during that time frame. We already has seen that. Obviously, rural communities have difficulty access to healthcare. They may sometimes have access to even telemedicine. Again, medically underserved populations is still at risk. They may also have some issues to accessing to healthcare. Again, in order to rectify this, again, individuals with prior abnormal findings need to follow up with current symptoms, should be triaged through the HELL or in-person visits as appropriate. Let's say if a patient has a previous history of breast cancer, those patients' screening should not be delayed. The patient has to see the doctor or has to have telehealth to see whether they have symptoms or they have to be screened or not. Again, the patients has to be encouraged, if they develop any symptoms, they should not be sitting on their symptoms, that to notify their physicians. If they have a symptom, they have to be promptly brought to the office or at least a telehealth visit to address those symptoms. Again, we have to identify the patient with high-risk mutations or high-risk populations, such as the patient with family history of cancers, patient with Lynch syndrome or BRCA mutations, this has to be prioritized, and these patient screenings or visits should not be delayed. Again, there are some risk prediction tools utilized to identify those patients integrated into healthcare so that we don't miss those patients during the follow-ups. So how is the healthcare access situation? What is the healthcare insurance situation? I mean, I was looking to that and see whether if any insurance losses during the healthcare. Again, job losses caused by the coronavirus threatened to disrupt healthcare coverage for millions of people. Because of lockdowns and quarantine, some of the businesses were closed. Employment rates fell by 6.2% from March to September in 2020. This would suggest that roughly 2 to 3 million people may have lost employer-based coverage. That's a very significant amount. That may also prevented the patients to come to the hospital. And again, there are too many unknowns, but the studies I have read, they state that those losses might be offset by Medicaid and other programs. But again, we don't have any long-term study at this point, and we'll see the long-term implications in the future. So with all these lockdowns and patients dying from COVID-19, missed screenings, missed physician visits, is it going to affect the mortality? I mean, because we got a very good mortality success in healthcare, in oncology over the last 20 years with improved screenings, with improved treatment methods, and we actually brought down the mortality rates significantly, and this was a great success. But unfortunately, COVID-19 disrupted that, or at least temporarily. And if you look at the model, especially for the breast cancer and colorectal cancer, this is a study from National Cancer Institute, and they essentially look into the breast and colorectal cancers that essentially account for the almost like 1/6 of all cancers. They do anticipate or predict 10,000 excessive deaths in the next 10 years. And if you look at the data, the majority of the deaths, essentially is expected in the first 2 years. And this trend is going to slow down. If you look at the curve is steeper here, and then it just plateaus. But the effects will be seen over the next 10 years. And again, this analysis does not consider other cancer types. It doesn't account for additional morbidities or upstaging that may also add up to the patient's complications, essentially. So research is integral part of oncology. That's one of the reasons I went to oncology, because I love the research. I want the novel treatment, and the cancer care was ever-changing field compared to the other specialties. Our research is our major source for treatment, and all the students comes from research. What happened is with the COVID-19, unfortunately, many cancer trials has been suspended. I have this issue personally. I mean, we essentially continued with our current trials to a degree, but when I had a patient who has essentially exhausted all the treatment options, and when I tried to send the patient to a tertiary care center for an appropriate clinical trial, and I noticed that some of the clinical trials were suspended, so we could not even offer the patient in therapy. This became a big issue. So this essentially became an issue for patient care, also for our future patient treatments. Again, massive disruptions occurred in clinical trial and research across the world. Trials actually deal with vulnerable population with COVID-19. Obviously, cancer patients are very vulnerable, and basically having the patient into clinical trial will require more often inpatient care. Also, this may affect the patient's outcomes in terms of mortality, and the researchers tend to suspend their clinical trials, especially in the beginning of the pandemic, to see how things would go. Again, conferences has been canceled. We had significant issues with supply chains for equipment, resources, experimental medications has been lost. Obviously, the funding went down. There was been significant widespread financial losses. And in certain areas, researchers had to be pulled away from working on clinical trials and to work in the emergency medical care, because some of the researchers, they have protected time. They do research in 50% of their time. They do clinical work and they basically did, patient research. Personally, I did this as well. For example, in my institution, we had to we started convalescent plasma clinical trial, and I was the only person who was capable of doing such research, and I basically allocate my time for COVID-19 patients, although this is not my primary area. And I remember I had almost like 45, 50 patients in my census, and I approximately spent like 3-4 hours of my daily time during that peak outside my cancer patients. I dealt with COVID-19 patients and enrolled the patient in clinical trials, get the data follow-up and so on and so forth. So this was a tremendous effort, and everybody shared that difficulty. What else in research? Again, pandemic has, so the pandemic basically disrupted research. Again, scientists pivoting their cancer research activities to other fields. Again, campus lockdowns happen. There are some phase 1 trials. Basically, there are postdocs. There are other people, non-physician people, staff had to be in the field. Obviously, they start working from home. They couldn't come in, and that's also disrupted the cancer care. And if you look at the survey, comes from the UK. They looked at the cancer research, and they found that there was significant delay in the cancer, and actually the setback would be an average of 6 months, and actually that may lead to a cancer advance almost like 18 months, because obviously everything is augmented. So if you have a delay in research, then the cancer research will slow down, and then the outcomes in terms of getting new drugs out in the system to the market will slow down. So there must be significant impact for the future for the patient care. Again, there is dramatic drop in new cancer drug trials. The most recent trial just came out last week. I just put this into my slides yesterday, actually. The most recent data suggests that 60% decrease in new clinical trials. And then during the 40-month observation period, they basically had 1,440 oncology trials in 91 countries, only 191 clinical trials since the COVID-19 hit. This is a significant impact. And we're going to see those outcomes in the next 10 years and see how it's going to impact our outcomes and drug development and so forth. And again, patient recruitment slowed down because of various reasons, as I mentioned, and fundraising revenue also went down, because to do research, you have to do fundraising, you have to get funding, you have to have basically money to do that, and that also went down. So this impacted our clinical trials. Again, but we still continued to conduct the research. And how did we do that? Obviously, in March 2020, FDA issued guidance to protect the patient's safety. And they stated that the researchers and clinical trial sponsors determine that the protection of the patient's safety, welfare, and rights by the best served by continuous steady participation in the trial as per protocol, or by discontinuation by the administration or use of investigation product, or even the participation in the clinical trial. So you basically just left it to the investigator. Again, it called the investigators and sponsors to coordinate with the institutions and ethics committees potential changes to the protocol as early as possible. Again, many policies and many articles has been published. Health Affairs posted a blog, and they basically examined the ways to maximize the utility of data, and they suggested that to prevent some disruption, they suggested decentralizing trial locations out of a few major urban centers. They suggest that many other institutions has to be participating in clinical trials in order to basically avoid those kind of limitations. Again, NCI also had started to address this issue. NCI also worked with the FDA to increase the flexibility and support of the clinical trials. Remote informed consent and other protocol deviation has been implemented. And also NCI reported some new clinical trials, funding opportunities at addressing the relationship between COVID-19 and cancer. Actually, we have studies going on. And again, NCI COVID-19 in cancer patient study is an ongoing study, and then we'll collect blood samples, imaging, other data to understand how COVID-19 affected cancer patients, and hopefully we will be having some information and data regarding this question. Okay, so now we have vaccination, and what are we going to do in cancer patient? Because this is the most common question I get in the office. Almost all my patients are asking, doctor, can we get a vaccination? We have cancer, we're on chemotherapy, we're on a clinical trial. Can we get vaccinated? This is a very important question to answer. Obviously, there's the FDA basically issued emergency authorization in 3 different vaccines, and the vaccines rolled out globally against coronavirus. There are different vaccines. There is a mRNA, viral peptide vaccines, plasma DNA, or inactivated or genetically modified virus vaccines. They are basically becoming available. And again, the data on safety and tolerability of these vaccines are currently limited because clinical trials did not include cancer patients. But since overall data shows it is safe, I can safely say that this is also safe in cancer patients. In my personal experience, I do not recall any serious side effects on patients, even on chemotherapy, who are getting the coronavirus vaccination. So European Society of Medical Oncology basically issued a statement about vaccination. Again, vaccinate all cancer patients with priority, collect data, monitor patients of who got vaccination with cancer patients, and see what their issues are, if there's any safety problem, there is side effects, any negative outcomes, whether they're benefiting from vaccination or not. Again, educate and basically provide confidence, because the patients needs confidence and reassurance from doctors. They look at the doctors and see whether this is safe or not. So basically give them confidence, but at the same time, keep yourself up to date and see if there's any new data on vaccination and cancer patients, and provide them on a monthly or weekly basis, or whenever they become available. Again, CDC recently updated some guidelines for fully vaccinated people. Now, fully vaccinated people can remain indoors without wearing masks if both of them are fully vaccinated. But obviously, if the fully vaccinated person goes into public, or if they're unvaccinated people with high risk, so they're supposed to wear masks. Again, she should get tested, experience COVID-19 symptoms, and then follow CDC guidelines. And again, for further information, you can always go to CDC website and get the information regarding this. This also may potentially apply for cancer patients as well. So this is also the other question: how is the COVID-19 vaccination and clinical trial will be affected? Because there's always a fear and concern that coronavirus vaccination may essentially induce some side effects. Cytokine release can happen. And obviously, would it affect the clinical trial? Because if the patient has a COVID-19 virus reaction, would this be attributed to the drug or to the virus? This is a very important question to answer. However, patients should not have to choose between enrolling to a clinical trial or receiving COVID-19 vaccination. So for this reason, if the patient needs a COVID-19 vaccine, the patient needs the vaccine, should get the vaccine. The patient should not be basically just left off because the patient going to a clinical trial. Again, benefits of vaccination by far outweigh the risks of adverse events. I definitely recommend this based on the current guidelines. Again, clinical trial sponsor has to guide the patients regarding their accrued trials, because different trials may have some different recommendations and basically rules. Again, what kind of precautions can be done? Again, there are some certain guidelines. Lancet Oncology basically published some guidelines. Nature magazine, Nature journal published some guidelines. So let's say if the patient was a phase 1 trial. So phase 1 trials means that the patient is on a brand new medication. The phase 1 trials, they are usually like a first in human trials. So they were never tried in humans. They usually come from animal trials, and this is like a dose escalation type. So they start low dose and they go at high dose, and then they escalate the dose and see whether the drug is safe or not. So any side effect while you're escalating the dose during a clinical trial, and if the patient get a COVID-19 vaccine side effect, it will be very hard to predict for the investigator which is coming from which, so that can be a quite challenge. So for this reason, for phase 1 clinical trials, they recommend avoiding the star investigation product until 2 to 4 weeks to avoid cytokine release syndrome risk after the vaccination. Let's say if the patient hasn't started the phase 1 trial and got the vaccine, so they recommend waiting for 2 to 4 weeks to make sure that the patient basically just passes all the potential side effects of vaccine and then start the trial after that. Or if the patient is already in a phase 1 trial and if desires to get the vaccination, get the vaccine, there is no problem, get the vaccine, but avoid the vaccination on the days of IV therapy. And then you can also determine the dose-limiting toxicity period, so you can basically just wait to give the next drug, outside that, period, so you can avoid like concurrent, toxicity issues. Again, if the patient's a phase 2 trial, so the phase 2 trial means that the phase 1 is completed, the dose is known, so the patient is getting a standard dose, there is no dose escalation. So essentially, you can give the drug based on the availability and with the timing based on drug mechanism of action. Obviously, there are certain other factors may weigh in. For example, let's say if the patient owns a T-cell depleting, agent or B-cell depleting agent like a rituximab or some other, antibodies that can actually hinder the immune system. So the immunity against the vaccine may not be as good. So this can be assessed case by case basis. But in general, vaccination should not be avoided just because the patient is on a clinical trial. Again, how did the oncology practice change during the pandemic? My practice changed, and every oncologist practice changed, and actually this catalyzed a rapid pivot toward virtual consultation. So we also implemented that. Obviously, which the patients needed to have in-person visit. We tried to do in-person visits. We basically changed the visitation rules. We did not have any visitors into the waiting areas. We limited the patients sitting in the visitation areas, waiting areas, and we also implemented a telemedicine or telephone visits. But the thing is, obviously, this is a risk factor because the patients are high risk for getting transmission and getting severe illness. But obviously, certain types of skills has been diminished, right? Rapport building, actually, transition to palliative medicine undermined because of the virtual consultation. Just keep in mind, those patients live a life and they live in a social environment. This also put a patient under stress. For example, there were patients who were at the end of their lives and they wanted to have a final meal with their family during Christmas. They couldn't have that because there was a lockdown, and obviously certain government institutions were recommending basically large gatherings and such, and the patients wanted to have their last wishes to be fulfilled, or those wishes basically required travel and so forth. So these basically brought significant challenges in oncology and patient care. And obviously we had to address that in the office all the time. Again, the paradox of access, again, as the COVID-19 began to unfold, actually the demand for healthcare services outstripped the supply. And again, questions of rationing determining essential or versus non-essential care become a central focus of economic modeling, ethical reflection, and social concerns, and we had to address those issues daily basis. Again, oncologists face the inevitable task of determining treatment versus threat of death associated with COVID-19, because just keep in mind, the patients come in and ask you, hey doc, I'm going to get a chemotherapy, I'm in remission, I'm getting maintenance. So am I going to die because of COVID-19? Am I vulnerable? When I come in, can I contract the disease? Again, these are the very important questions to answer. And again, we did not have sufficient data in the beginning. Now we have some data. I'm going to talk to you about that in a minute. Again, standard therapeutic approaches are being altered or delayed, including surveillance. Again, non-emergency surgeries has been postponed, clinical trials suspended. Again, allocation of healthcare workforce. This has happened in all across the board. Actually, just a trial came out just yesterday. I couldn't put it in the on the presentation, but there was a trial. There was a study came from England. Even radiation oncology services came down for certain patients, but actually went up for certain patients. For example, for head and neck cancer patients, the radiation services went up because for those patients, surgery can be done up front, but surgery is an option. Radiation is a very reasonable option. But I understand that since the surgeries were postponed, many patients' surgery got delayed or canceled, and those patients diverted into radiation oncology. So therefore, some of the patients actually got more radiation, but whereas the other diagnosis went down because of lack of diagnosis and such. So in general, radiation oncology case also went down along with the oncology cases. Okay, so again, the biggest question, would cancer treatment worsen the infection? Am I at risk? Again, there are certain studies has been published to answer this question. Again, Memorial Sloan Kettering Cancer Center looked at their patient population, and they determined that standard or traditional chemotherapies basically does not affect worse outcomes, but treatment with checkpoint inhibitors are predicted for hospitalization, severe disease. But again, recent chemotherapy, major surgery with this last 30 days was not associated with severe complications. So that's the reason you can say the patient that most probably the chemotherapy alone would not increase the the COVID-19 complications, but just keep in mind those patients are already vulnerable. There was another study came out actually from China. They basically looked at the meta-analysis. They looked at 17 observation studies, including 3,268 patients. Pooled mortality was 24.8%, which is consistent with the standard data in high-risk patients. The risk factors was male age above 65, comorbidities, hypertension, COPD. But again, recent anti-cancer treatment did not increase mortality. Again, antibiotic use, glucocorticoids, interferons, ventilations was associated with high probability of death. But again, chemotherapy alone did not increase the risk of death in COVID-19. Okay, so how about the clinician and patient experiences? Again, our patients' experience has significantly changed. The way we communicate the patient, the way we transition the patient. And again, we had to communicate with the patient families, so many phone calls, so many telemedicine visits happened. And again, we looked at our patients' satisfaction data. We had a slight decline because some of the patient families were complaining that they were not being basically included in the decision-making process, probably due to the fact that they were not available at the time of the visit. So we implemented certain measures, for example, getting the patient's family to a phone call as like a participate in the visit if you're having a important conversation about treatment management. So we try to include the patient's families as well. Again, there are certain principles. Returning to pre-pandemic conditions, not likely in the short term. Again, the economical, physiological aspects has to be assessed to ensure the equity access, safety of the staffs and the patient is still a priority. Rapid evaluation of the best practices has to be rationed. Again, interpersonal and technological ramification of telehealth needs to be targeted to basically assess the patients. Again, rigorous analysis of clinicians' assessments of value of life. Their understanding of COVID-19 must be undertaken. And obviously, palliative care issues in the elderly patient care, patient with comorbidities has to be also addressed. Again, this is a huge healthcare problem, has to be reassessed daily basis. Palliative care is also important because we don't just treat the patients for cancer, we also give them palliative care, and hospice also is another aspect of cancer care. This has been, disrupted. Again, palliative care population is the most vulnerable population against COVID-19. Again, telehealth has been utilized, but again, the telehealth is not the same as the inpatient visit. Again, providing empathy, displaying empathy by phone or video is a big challenge. Again, we try to allow the patient to be emotional, and we try to get their families involved, especially when they're getting telehealth visits or telephone visits. I try to get the patient families involved so they don't feel like they're alone and such. But this actually became a significant issue. So how are we going to get back to normal? Hopefully we'll get back to normal in the future. So since the vaccine rollout and such, again, the pandemic should be under control nationally and globally. Again, there are ongoing challenges, and healthcare systems must be very proactive to facilitate patient safe return back to cancer screenings and cancer care. Reminder systems has to be implemented. Again, utilization of telehealth. Again, clear and disseminated strategy to how the patient will be prioritized. If the demand exceed the capacity in the future, again, encourage the patients to get their screening and addressing their common concerns, and also reassure them the hospital is safe, the safety measures has been undertaken. What do patients need to know? These patients need to know, again, they have to need their risk of contracting COVID-19 with delay of cancer diagnosis. Obviously, having here aches and pains over there, doesn't necessarily mean that you have cancer, but you're having a symptom severe. If you coughed up blood, if your stool has blood in it, if you're losing weight unintentionally, if you miss your cancer screenings and you have significant, past medical history of cancer in the family, you have to contact with your primary care physician or your oncologist, or at least you have to give them a call. Because just keep in mind, inpatient visits are not necessary. You still can contact with your physician through medicine or telehealth, and you can address these concerns, and you can trust your physician that they will be addressed appropriately. So an inpatient is necessary after the initial telehealth visit. It will be done. Test necessarily, that will be definitely done. But like fearing that you're going to get COVID-19 is not a rational thing to do. Again, decision aids are available in the online that can be useful. Again, patient must believe that the benefits of cancer screening outweigh the risk, and obviously most facilities implement a strategy to protect patients. Mask requirements, social distancing, spacing out appointments. These are the strategies basically the healthcare systems are implementing, and the patient need to know that they're working around the clock to achieve that. They're working very hard on that, and so do we. Again, in conclusion, COVID-19 has significantly disrupted the routine preventative care and cancer screenings. Hundreds of thousands of patients and visits has been missed during that time frame. And then obviously there are virus infections are still ongoing, and this is an ongoing problem. Hopefully we're going to fix it in the soon. Again, healthcare systems must implement proactive interventions to facilitate patient return to cancer screenings or treatments, particularly those at risk of harm as a result of deferred care. That's basically it for my presentation, and thank you very much for attention. So I'll take some questions for a few minutes now.